Hi everybody, welcome to pre-record session 3, and in this session we're going to talk a lot more about how we might recognise signs of sexual abuse in children and young people. So here you can see the research and practice tool, and I'm going to present two tools to you in this section, but this one is really handy because intrafamilial sexual abuse is going to be the one that you're probably going to come across most, and also because there's quite a lot of detail in it, but also we're going to talk about the CSA Centre toolkit as well. Let's start by thinking about the more obvious signs that I think we're probably slightly more experienced at, and that's physical injuries. So if you consider what happens within sexual abuse, then it's not surprising that you might find injuries around the genitals, the anal area. There might be bleeding or pain or discharge. Children might have problems with urination. And so we talked earlier, didn't we, about children and young people being uncomfortable when they're sitting, for instance. Maybe they talk about being sore. Maybe they've got UTIs, urinary tract infections. Or it might be that there's a pregnancy, for example, or warts around their mouth or their genitals. Some sexual abuse can be quite violent, so there might be bruises or scratches or bites. We also know that you're likely to see physical injuries potentially because children will display those injuries on their body sometimes. So maybe they self-mutilate or self-harm. Some children and young people take control of their eating as a means of something to control. Maybe they're controlling their emotional regulation through substance misuse. So all of those things you can think about in the kind of physical realm of what we might see. Some of these things cross over into psychosomatic and other aspects, but it's just to help us kind of remember the extent and breadth of some of the symptoms. You can also see here that I've got that image of common sites for injury in children, and then non-accidental injury sites, which can be quite good to just sort of remind ourselves of sometimes. Then there are the psychosomatic functional disorders. So these are the things that are related to the abuse but are not a direct link to the abuse. So for example, one of the ways that a child might take control of their life when they are very much out of control with the abuse is to very much withdraw, to just refuse to take part in any aspect of life. Maybe they disassociate so that there are times when you feel like they're just not present emotionally. Their body is there, but they don't seem emotionally present. Some children have what looks like an epileptic seizure, but actually it's a dissociative state which is related to the trauma. And so if we think that a child is having an epileptic seizure, for example, we need to be sure that they've been diagnosed with epilepsy and not just assume that that's what it is. Many children suffer from irritable bowel syndrome. A lot of stress is located in our stomachs, and if we're in a state of fight or flight all the time, then that takes its toll on our digestive system because it's always overactive. So consequently, children might talk of a stomachache a lot or a headache. So they're related to the abuse, but they're not direct result of the abuse. And then drug and alcohol misuse, again, commonly seen in the behaviour of people with histories of sexual abuse. As a drugs worker, it got to the point where I would almost expect my clients, people who use the service, to say that this was part of their history because it was so common in that client group. Some more functional disorders, as we've said, headaches, migraines, the smearing of feces, children who've been toilet trained still soiling their clothes, for example. Other types of eating disorders, including overeating. Some children talked about wanting to make themselves unattractive, and so they just kept eating in the hope that that person would leave them alone. Or it might be that a child wets themselves in a stressful situation, And again, that's a perfectly normal trauma response, and hopefully would be seen as such and could be part of the evidence base for the abuse. So emotionally, we might see children who have sleeping problems, mood swings, have fears about people or places, who maybe seem distracted or have other types of post-traumatic stress disorder. They might fear intimacy or be over-intimate. You might see children regressing to some much younger behaviours like sucking their thumb. Or you might recognise that they find their own bodies repulsive or see themselves as repulsive and shameful. And again, we need to ask ourselves why. So some of the behaviours that we might see, there might be sexualised behaviours, games, sexual play with other children. There might be excessive masturbation, aggression or violence, unusual personal hygiene. So many things that are quite key to evidencing sexual abuse and would be really unusual to see in children who hadn't been abused. There's also that concept of sexual promiscuity that we hear about in the training room. Oh, that child's promiscuous, so they have a lot of partners. And thinking about what that means and why that is for that child. Because it's unlikely to be that they really enjoy sex. It's much more likely to be that sex is a way that they have been shown that love is shown through sex or needs are met through sex, and consequently maybe that child has ideas about themselves and their body and sex, which then translate in behaviours of having sex or encouraging sex with other children. Maybe those children leave clues to have discussions around sex. Maybe we see that they have new toys or gifts. Maybe they say things that make us think, oh, where did you hear that word from? Or that's an unusually sexualized term for a child. Or maybe that's a child that's running away and that's persistently missing from home. Here you can see I am featuring a different toolkit, which is the one from the CSA Centre, which covers all spectrums of sexual abuse. So it's equally useful and best to have both of them really. So I've given you an example from the toolkit where they talk about behaviours in children which can indicate sexual abuse. So they might be around that the child wants to report it, but they don't do it directly, but they will drop hints and want to talk about sexual issues. So maybe they're asking questions about sex, or they're drawing things that are sexual, or maybe they're writing poems, or they're drawing frightening images. Somehow they are showing you through their sexual behaviour that there is something about sex that they want to discuss. And especially if it's then linked with images, which represent fear. They may also show you from their emotional distress. So it may be that they have a fear of going to the dentist or other types of medical treatments. They don't like being in positions where somebody else is in control. Maybe they have emotional responses to, a particular gender or a type of person, or maybe there's a space or other types of triggers that you might notice, which could indicate that they have fear attached to people or places or certain things. And it might be that they have changed their relationships with people, or their behaviour has changed in some way recently. So yeah, there's a whole list of indicators that you can have a look at in this document. So they also separate them into different areas. So for example, physical signs, that might be things like urinary tract infections, fidgeting in their seat, holding themselves in a way that shows you they're not very comfortable. Or it might be the ones that we talked about earlier, the psychosomatic ones. So this toolkit features those as well, wetting and soiling, for example. Again, thank you for listening, and please make some notes, come back with your reflections, and we're going to do further case study work in the next section.